Good evening, ladies and gentlemen, and welcome to Battling and Beating Cancer on CAN TV 21. I'm Scott Seaman, co-founder of the Chicago Blood Cancer Foundation, doing it solo tonight in terms of having Charlene have the day off, but not in terms of our special guest, and we're going to introduce Dr. Gregory to you in a moment. Once again, we're pleased to be able to come into your living rooms, help you out after dinner with some good information, helpful information, important information about cancer. And Charlene always says that 1 out of 2 men and more than 1 out of 3 women in America at some point in their life are going to get a diagnosis of cancer. But the good news is it's not like the old days. There are so many treatments, so many options, and people are doing so well with so many forms of cancer. And part of the whole thing is knowledge, advocacy, and investing in research. And in Chicago, we're particularly blessed because of the fabulous institutions and doctors that we have here. So we thank you for joining us on CAN TV 21, or if you're watching us anywhere in the world as we stream live on cantv.org /live. And on tonight's show, we're going to be talking about lymphoma. And as you know, that's a subject that's near and dear to my heart because I am a 14-year survivor of non-Hodgkin lymphoma. And because at Chicago Blood Cancer Foundation, our mission is to cure all of the blood cancers, lymphoma, leukemia, and myeloma. And we do that by raising money, by raising awareness, by educating and advocating on behalf of issues that are important to people. And so you can see earlier on the screen, and we'll put it up later if you need to reach us, it's chicagobloodcancer.org or 888-792-9992. So February in Chicago and on CAN TV is Follicular Lymphoma Month. And the reason for this is that Chicago Blood Cancer Foundation and Rush University Medical Center and Cancer Center this summer, well, actually it was on September 15th, which was World Lymphoma Awareness Day, we held follicular lymphoma on the road to cure, a patient educational forum, and we had the best doctors from all across the world coming in and making presentations on what follicular lymphoma is, what the treatments are, the traditional ones and the emerging ones. And Dr. Gregory shared that and, of course, was the superstar of the day.
It was a great day.
And
all of you.
And you all will get to watch that on CAN TV. They've divided it into 6 segments. It'll air at various times in stations on the CAN TV network, and you can check our chicagobloodcancer.org website for times, or you can watch the actual videotapes on our website. So you're going to get to see Dr. Gregory and doctors from across the world. And we're going to talk a little bit about follicular lymphoma as well. But we're going to talk about all types, or many of the types of lymphoma. And lymphoma really is the most common blood cancer. It's one of the most common cancers in children. And the rate of non-Hodgkin lymphoma, which is one of the 2 major forms, have nearly doubled since the 1970s. And there are about 70 types of lymphoma, and it's really a cancer of the lymph system and of the white blood cells known as lymphocytes. And these are the white blood cells that go and fight infection and disease. So really, lymphoma is cancer of the immune system. And so let me just introduce to you one of the great minds in lymphoma. Dr. Stephanie Gregory is the Elodia Kehm Professor of Medicine at Rush University Medical Center, Rush University Cancer Center, Professor of Medicine. She heads up the lymphoma and the what we'll call the hematological malignancies at Rush. And she won't tell you this because she's so modest and she really doesn't care. What her concern is treating patients and developing research. But she is among the top 1% of hematologists, oncologists in the world. And so if you factor all that in and then you sprinkle a healthy dose of compassion for her patients and a good kind of feistiness, willing to really help her patients, get them the right treatment, and do whatever it takes to make them better and get them over and get them through the disease.
I'm going to kiss you.
That would be
very
would
soon.
Be wonderful. But welcome and thank you so much, Dr. Gregory, for all that you do.
I love doing this. It's 40-some years now, so it's really getting there.
So she's now 40-some years old.
Yeah, I was very young when we started this. But thank you. Well, you know it's my passion. physician. I love to work with patients. I love to, we have so much that we've accomplished in all of these years with so many people. I mean, at Rush especially, it's been my home for many, many years. We've been able to collaborate with the other great medical centers in the city of Chicago, and I think we're making unbelievable progress in lymphoma, and we collaborate all over the world really with physicians who their main interest is to cure these many, many different types of lymphomas.
So let's jump right into it.
Okay.
I said earlier that two major types, Hodgkin and non-Hodgkin.
Okay.
We're going to spend most of our time on non-Hodgkin, but let's talk a few minutes about Hodgkin, what it is.
Right. So actually, that was the first lymphoma that we actually could talk about a cure in. And the Hodgkin lymphoma is seen more in young people. The peak incidence is between 15 and 30 years of age. It is not increasing in incidence. There are about 8,000 cases a year, and it's a very curable lymphoma. It tends to spread in a different way than the non-Hodgkin lymphomas. It tends to spread from one lymph node area to another. So if it starts in the neck, it goes to the chest, from the chest into the upper abdomen, and upper abdomen down into the lower abdomen. Whereas the non-Hodgkin lymphomas, they can have one here and one in the groin area. It's a multi-centric kind of spread. But it's what the pathologist sees under the microscope that makes the difference. He sees a classic cell for Hodgkin. It's called the Reed-Sternberg cell, diagnosed by a woman and a male physician years ago. And major advances have been made. So we're talking about 80 to 90% cure in the Hodgkin lymphomas. And there are 3 or 4 different types of it, but in general, most of the patients with Hodgkin lymphoma are curable. We've got a very, very small resistant group of patients with Hodgkin lymphomas, and those are the patients that we try to get through into transplant. Sometimes their disease may come back after transplant. Then we have to try to do a transplant from a different type of a transplant from a donor. And a revolutionary new drug was found and approved in the past year or so for that kind of relapsed Hodgkin lymphoma. It's a small percentage of patients, but it's, again, a new miracle drug, and we can maybe talk about that later. Non-Hodgkin lymphoma is the one that we really spend most of our time on now because it's 70,000 new cases a year. It's the 5th or 6th most common cancer in men and women. We have an increasing prevalence of the non-Hodgkin lymphomas because patients are living longer. So the incidence is increasing a lot. People are around longer. We lose about 20,000 patients a year dying from the non-Hodgkin lymphomas.
And so in terms of treatments, just briefly, for the Hodgkin's lymphoma or Hodgkin's disease, as it sometimes is called?
The standard approach in the United States has been a combination of drugs. They are chemotherapy drugs. They're referred to by their first initial of the drug. It's ABVD, stands for adriamycin, bleomycin, Valban, and DTIC. They're the
And we're going to quiz you on that later.
Yeah, so
ladies and
remember
gentlemen.
that. And it's given every chemotherapy drugs are given every 2 weeks, and the majority of patients receive about 6 months of this treatment. Our goal today is to really minimize the amount of treatment that we give to Hodgkin lymphoma patients, because what we realize now is years ago we were curing so many patients, and we couldn't decipher which ones needed more treatment, which needed less treatment. And so we started to see long-term complications from the treatments we gave patients. And years ago, we gave a combination of drugs called MOP chemotherapy. And we often then gave them radiation therapy after that, extensive radiation therapy, because we wanted to hit all the potential lymph node sites. And many of those patients were cured for years and years, but they seemed to die sooner than the normal people in the general population. And when we looked at all those reasons, it was because they were getting complications from the chemotherapy and the radiation therapy. So in young women, they got breast cancer, and we were starting to see coronary artery disease in younger women. Men were dying earlier with heart disease from the radiation. And so all of those treatments now have been streamlined, and we're doing less treatment for earlier stage and a little bit more treatment for advanced stage, and still curing patients and seeing less toxicities and less early deaths.
And so that's really, the goal is obviously first and foremost effective treatment.
And
minimize the side effect, the toxicity of treatment, and the inconvenience to the patient. And as you mentioned, partly because of the success with Hodgkin lymphoma, for years and years, no new drugs or treatments. But you mentioned when I'm going to take a shot at it, brentuximab.
Brentuximab vedotin.
Okay.
Very good. So, you know, we are trying to develop small molecules now, and we're trying to develop non-chemotherapy drugs that will deliver treatment and kill the cancer cell, but not kill the normal cells. Chemotherapy is like taking a big hammer, hitting somebody over the head, and everything goes for a while. And then, if you're lucky, some of the cells recover, and hopefully you can live and get rid of a few of the cancer cells. Novel therapies today are targeted therapies. They're actually looking at delivering treatment to the cancer cell, trying to spare the normal cells. And the normal cells that really are so sensitive are the bone marrow cells, the hair cells, the GI cells. That's why you get nausea. That's why you lose hair with chemotherapy drugs. A lot of the novel therapies today are really small molecules. They go in, they hit the cancer cell, and they're not terribly toxic. So we'll talk about a few of those. And more excitingly is the fact that some of them are pills, not even intravenous drugs anymore.
Yeah, and so let's segue a little bit to the non-Hodgkin lymphomas, and over 60 types, and we're not going to be able to cover all of them, but there's 4, 5, 6 types that
Really
are the
common.
most common, and I think we could at least make some good headway. And to most people, if you say ash, they think, well, that comes from a cigarette. But when we say ash on this program, we're referring to the American Society of Hematology, and they had a big get-together with all the leading doctors from across the world, including Dr. Gregory. And so we're going to talk about some of the developments that we learned as recently as December of last year.
I mean, Scott hits on a very important meeting. I've been going to these meetings since the first one. I think it's 54 years now they've been having the American Society of Hematology. It's always in December. And about 15 to 20,000 hematologists came from all over the world to these meetings. They brought their research. The sessions went on for 5 or 6 days. And we learned a great deal. We learn a great deal every time we go to these meetings because everyone comes with great minds. There's a lot of very basic science, but a lot of very important clinical data that we bring back to our institutions, and we try the new agents. So
let's start with large diffuse B cell.
Diffuse large B cell. I have to remind everyone that the study of cancer and the treatment of cancer, even though we call it oncology, really started with hematology, and it was the very, very brilliant early hematologists who were studying the blood that realized that there are cancers of the blood, and the first cancers they often found were leukemia. And leukemia means white blood, and the early doctors would take a sample of blood, and they'd see, instead of mostly red cells, they'd see a big layer of white cells, and that's how leukemia was diagnosed and talked about. And it was right after World War II that we started curing patients with leukemia, with lymphoma, and it came out of the development of war gas, nitrogen mustard gas, and they were some of the first chemicals used, but they actually did cure cancer. So that was the beginning of the study of oncology, really, through the development of treatment of leukemias and lymphomas. Right. All right, so getting to diffuse large B cell and ASH, we know now that all cancers, even though they look the same under the microscope, are not the same. And so diffuse large B cell is the most common non-Hodgkin lymphoma. We cure about 50 to 60% of patients with a regimen called R-CHOP. And in recent years, we realized that some patients, it looked the same cancer under the microscope, but some did well with R-CHOP, some did not very well with R-CHOP. And before that, it was CHOP without the R. The R stands for this new monoclonal antibody rituximab that actually asks the immune system to come in and kill the cancer. So several years ago, the diffuse large B cells were looked at as far as their genetic makeup. And we looked at something called their gene expression profiles. And what we found is that not all diffuse large B cells are the same. There are two very different genetic makeups of them. One is called the activated B cell, and one is called the germinal center B cell. And it just depends on what kind of genes make up the assay of the tumor. The germinal center diffuse large B cell has a much better prognosis than the activated B cell. And so now a lot of direction is going to clinical trials looking at whether we can add some drugs, new drugs, new what we call immune modulators or proteasome inhibitors to the R-CHOP regimen to see if we get better results in patients who have the so-called activated diffuse large B cell. Not everyone can have their gene expression profiling done because it's thousands and thousands of dollars. So we do have a poor man's assay of looking at them. Our pathologists have become very, very good at doing certain stains on the tumor, the diffuse large B cell, and by looking at some stains that are positive, others that are negative, they can actually say, oh yes, this looks like it's a germinal center B cell, and this looks like it's a so-called non-germinal center B cell, or the activated B cell. So all of us now, when we have patients in the academic centers, and a patient comes with diffuse large B cell, our pathologists will say, this is germinal center, this is non-germinal center, and it's about 80% accurate. Yeah. Okay.
Which is a huge advancement, because 15 years ago, back in my day when I was going through the treatment, we didn't know this. We just knew that the chemotherapy worked on some patients and on others it didn't. And by discovering the difference, it's leading down the road to figuring out different agents that can treat the different types of lymphoma differently, and the results for the patient much better.
And what we learned is that the pathways of the cancer dividing, the cell dividing, are different pathways, and that the so-called activated or non-germinal center diffuse large B cell has a different pathway called the NF-kappa pathway activation. And so drugs like bortezomib or Velcade, which many of you may have heard about for multiple myeloma, is now being added to R-CHOP in a clinical trial. We have that at Rush, and it's actually at the point of being sort of evaluated right now by the major companies that are running that trial.
And so, very exciting time. Large diffuse B cell, overall, a very curable disease for many patients. And if the chemos and the immunotherapies don't get it, sometimes stem cell transplant. And then you go, so that's the most common type of non-Hodgkin lymphoma. The second most common type is indolent or slow-growing lymphoma called follicular lymphoma. And again, all the information you can want from the symposium is available to you. But can you just tell us a little bit about follicular lymphoma and where we've come in terms of treatment developments?
So I think it's important to understand that indolent lymphoma means that it's slow growing. It probably takes, sometimes our patients have had this for years before we diagnose it. And in general, when you hear indolent, it means that it's not curative. But, when you say that to a patient, they say, you mean I have a cancer and you can't cure it? Patients, we are making this a chronic disease. I mean, when I started out, patients were living 8 years. When the last I heard, the median age is up to 14 years. But that doesn't mean everybody lives till 14 years. I have patients 20, 25 years. Many of them have had no treatment for many, many years. When you hear indolent, you don't want to rush in with treatment unless the patient is symptomatic. What happened years ago, every time a doctor saw somebody with an indolent lymphoma, if they had a new lymph node, they got more chemotherapy. Might have held them for maybe a year, and then new lymph nodes popped up. They thought, oh, we have to treat it again, so more chemotherapy. And in the lifetime of a patient with an indolent lymphoma, they might have had 7 or 8 different chemotherapy regimens. Did they die from their lymphoma? No, they died from a secondary cancer from all the chemotherapy they received. And that cancer usually is called myelodysplastic syndrome or acute leukemia, and those patients usually die within a year.
So for a lot of patients, the number one treatment is something called watch and wait. You watch,
and
you monitor.
You monitor.
And unless the disease gets real big, that it presents symptoms to the patients or interferes with an organ, you let them go. One of the big issues recently is Rituxan, the monoclonal antibody, which is, you call it vitamin R because almost all the B-cell lymphomas gets a component.
Get Rituxan with it, yes, absolutely.
And
you were asking me about the follicular lymphoma. So it's the most common indolent lymphoma. It's about 22% of all of the lymphomas. The diffuse large B cells, about 34% of all of the non-Hodgkin lymphomas. So the follicular has most of the research done with it because it's the most common low-grade lymphoma. And what we've learned is that going in with early treatment doesn't cure a patient. It just gives them more toxicities. And so if they have no symptoms, and if they don't have a lot of large lymph nodes throughout their entire body, or if their bone marrow isn't totally impaired, so they have low blood counts, we watch and we see them every 3 months. We do a good physical examination, we do blood work. how often we do CAT scans varies. We used to do them more often than we do them now because everyone's worried about the radiation you might get from CAT scans. And I think some of us are down to the point of doing a CAT scan once every year or once every 2 years if the patient has no symptoms. If a patient can't possibly deal with not having a treatment for a cancer.
So if their watch and wait is watch and worry because they feel they have cancer and they need to do something,
then we do suggest a single agent rituximab. It's not chemotherapy, it's immune therapy. We give 4 weeks of it. We usually then do a CAT scan a couple months after they had their 4 weeks of Rituxan. Most patients will get a response, and there's some very nice data showing that some patients with only 4 weeks of Rituxan, if they have asymptomatic low tumor burden, can go 5 to 8 years with only those 4 weeks of treatment and no other treatment.
Yeah. And I mean, there are patients out there 15 years or more who have never required treatment. It's variable.
Right.
And
so we often define whether or not a patient needs treatment or not by something that the French have used for quite a while. It's called the Guelph criteria. It stands for the initials of the French group studying these low-grade lymphomas, and it just it includes some very practical things. If your patient has fevers, night sweats, weight loss, they need treatment. If they have big lymph nodes on CAT scan and physical examination, and by big I mean bigger than a lemon, bigger than an orange, bigger than a grapefruit, they need treatment. If they have blood counts that are not normal because of involvement of the lymphoma in the bone marrow, they need treatment. If they don't have any of those, we can really continue to watch them or use single agent Rituxan.
And let's just talk about some of the new things, some of which in some cases are not necessarily new, like bendamustine, but all the various kinase inhibitors. There's a bunch of additions, but can you just spend a minute or two walking us through some of the things that are really promising?
So years ago when people needed chemotherapy, there were 2 or 3 regimens. One was called CHOP, which I already talked about. That's for diffuse large B cell. There's a regimen that drops the H part of it, which is adriamycin, and that's called CVP. And these
could be called COP.
Or COP, COP, right. And these were commonly used treatments. All of them contain prednisone, and most of these patients are older patients. Prednisone is not easy to take. It makes you hyper. It can cause diabetes. It can give you fluid retention. It can
give you moon face a little bit.
Lot of side effects. And so we've actually been looking at new agents that may be as effective or more effective. And so after World War I, when the wall World War II, after the wall came down, Eastern and Western Germany, in the 90s, we realized that communist Germany had made a drug called bendamustine. And it was similar to Cytoxan, except it also had some characteristics of another group of drugs called purine analogs. And one of those drugs is fludarabine. And it was more effective than Cytoxan. It actually worked in people who failed Cytoxan, the C part of the CHOP and CVP. And so everyone got on the bandwagon for using bendamustine. And so bendamustine has been compared to CHOP treatment in follicular lymphoma by Dr. Rummel, a very prominent German physician who spoke at our symposium in September. And he has shown that bendamustine Rituxan is more effective than the R-CHOP regimen, no hair loss, less low blood counts, less infections, and better responses. And so everyone changed from CHOP or the CVP regimen to the bendamustine Rituxan regimen. And most of the new agents that are being tested, there are a lot of new monoclonal antibodies like Rituxan, the companies are adding those to bendamustine rather than to CHOP like they did years ago. A more recent study at ASH this year actually did the same study that Dr. Rummel did. Dr. Rummel did his in Germany. We did ours in the United States. And what came out of that is, yes, bendamustine Rituxan is less toxic, but this second study showed that it's probably not more effective than R-CHOP. It's as effective. So it was called a non-inferiority study. Bendamustine Rituxan is just as effective as R-CHOP or R-CVP, but it has less toxicity. So many of us are using bendamustine Rituxan.
So in our final few seconds, can you just talk about kinase inhibitors a little bit, and maybe 1 or 2 interesting clinical trials that Rush and you are participating in?
So pathway. These are there are a group of enzymatic reactions that occur in the cancer cell, and they're called pathways that lead to the cell growing and growing and growing. Normally, a cell, by these signaling pathways, they're told to die. When normal cells die at a certain time when they get older. Cancer cells don't die normally, and it's because there are mutations in these enzymatic pathways. And so the new development of treating cancers, all types, are called pathway inhibitors. And so the big pathway inhibitor that is very popular is something called the BTK inhibitor. It's Bruton's tyrosine kinase inhibitor. It now has the name called ibrutinib. It's a pill. It's used in relapsed follicular lymphoma with some very, very good results. It's being combined with other drugs, and Rituxan's one of them. And so we're looking at a lot of novel treatments that are non-toxic. So that's one of the pathway inhibitors. Another pathway inhibitor was called CAL-101. It now has the name GS-1101, and it's another oral medication. So we're really doing quite well.
All right, we have a caller. We'd like to take a caller real quick. Carrie, I think your question concerned the symptoms of lymphoma?
Yes, correct.
So, Doctor, just quickly.
So most of patients with lymphoma actually have no symptoms. They actually have find a lymph node in their neck. It's asymptomatic. There's no problems with it. And they go to their doctor and they say, look, I have a lump in my neck. And the doctor says, either, oh, we need to do something about that, or, oh, do you have a sore throat? Let me check you and see. A lot of doctors, unfortunately, will give 2 weeks of antibiotics for any kind of a lump in the neck. If it's not painful, it's not an infection, and it doesn't need antibiotics. So a painless lump is the most common manifestation of a lymphoma.
In the neck, the head,
usually
the groin area.
Yeah, usually the neck, could be under the arms, could be in the groin. If the lymphoma has had a chance to grow and the patient didn't pay attention to the fact maybe they were more fatigued or they were a little dizzy or something like that, then you get symptoms that are quite advanced. And those are fevers, night sweats, and I mean drenching night sweats. You have to change your night clothes, get up, put something else on. Weight loss. 10% of the body weight in 6 weeks is considered symptomatic weight loss for lymphomas. So fevers, night sweats, weight loss. More subtle findings is if the tumor's had a long time to grow and it's not in the neck or under the arms or in the groin, but been growing in the abdomen, nobody can diagnose something growing in the abdomen until it gets so big that you either look pregnant and a big lump is felt, or the growth has gotten so big that it's pressing on the blood vessels in the leg, and you get a swollen leg and a blood clot.
Well, Dr. Gregory, thank you so much. And in fact, the only way we can top this show is to bring Dr. Gregory back next week. And Charlene is going to talk to her about leukemia. And leukemias are the second most common blood cancer. So we will see you back here. Our thanks to Dorothy, to Christy. And we'll see you next Thursday on Battling and Beating Cancer. Thank you, everybody.